Obstetric Anesthesia, Basic Physiological Concepts in Neonatal Resuscitation 2, Hernando de Soto. In this lecture modules, we will talk about placental drug transfer and labor analgesia and anesthesia. Placental drug transfer. Question: which of the following characteristics of a drug is more likely to increase placental transfer? A. Low lipid solubility. B. Small maternal drug dosage. C. Large molecular size. D. Low degree of ionization. E. Decreased uterine blood flow. Correct answer is low degree of ionization. This is because only the non-ionized fraction of a partly ionized drug crosses the placental membrane. It is known that the degree to which a drug is ionized depends on its pKa and the pH of maternal blood. And most drugs that we use are poorly ionized in the blood, and they therefore diffuse readily across the placenta. The other answers do not affect placental transfer readily. The Fick principle, which responds to the rate of drug transfer, talks about the rate of diffusion being equal to a diffusion coefficient times the surface area of the membrane times the difference between maternal and fetal concentration over the thickness of the membrane. So what are some of these factors that affect placental transfer? There are drug factors. Number one, perhaps the most important, is protein binding, in which a highly protein-bound drug is affected by the concentration of maternal and fetal plasma protein, which varies with gestational age and disease. Albumin, which has a lower binding affinity, increase the transfer of drugs, and alpha-1 acid glycoprotein, with a higher binding affinity, decrease transfer of drugs. The second big one is degree of ionization. If I can take you back to school with the Henderson-Hasselbalch equation, in which pH equals the pKa of a drug plus the logarithm of the base over acid. In pregnancy, pH gradient between mother and fetus is very important. Fetal acidemia enhances the maternal to fetal transfer, causing the concept of ion trapping of basic drugs, for example, local anesthetics and opioids. 2-chlorprocaine is a perfect example of this situation. Lipid solubility, obviously, is very important. Charge of molecule, succinylcholine is very highly ionized versus thiopental, which is relatively non-ionized. What about molecular weight? Heparin, we know that is 6,000 Daltons. Warfarin, 330. Hence, very hard for heparin to cross the placenta, while warfarin or Coumadin easily crosses the placenta. Same thing happens with insulin in the diabetic patient. Insulin, because of high molecular weight, rarely crosses the placenta, or it's very hard for it to cross the placenta, while hypoglycemic drugs used in type 2 diabetes or non-insulin dependent will cross the placenta. Another factor is altered pharmacokinetics. Altered volume of distribution of drugs due to increased total body water, progressive depression of hepatic microsomal enzymes, increasing the elimination half-life. Fetal factors. There's a little algorithm that helps in remembering these things. Differential regional distribution of blood in the fetus with hypoxia or intrauterine stress causes redistribution of blood flow with higher drug concentration to vital organs. On the other side, differential regional distribution of blood in the fetus causes maximum drug concentration in the liver, which can affect immature enzymes. But again, easy to understand why it is so important to prevent hypoxia and intrauterine stress. Also, from fetal factors to metabolic capacity and metabolic enzymes in the liver like glucuronidyltransferase and immature, leading to increased half-life. Maternal factors, drug concentration in maternal blood flow, the decreased perfusion leading to decreased placental flow, leading to less drug transfer. So hypotension or aortocaval compression may obviously decrease placental flow. Better placental function in low segment C-sections, larger doses to reach the fetus, minimal effective dose should be used in these cases. Also, disease status alter placental transport, for example, in cases or disease of preeclampsia. So placental factors, placental binding, placental metabolism, diffusion capacity, gestational age in which the placenta is more permeable in early pregnancy. There's also the air of the placenta that can be decreased in certain conditions, for example, in abruptio placenta, maternal hypertension, etc., leading to increased transfer of drug. So the total drug dose to the infant equals the maternal concentration times the ratio of fetal to maternal ratio of drug. The fetal-maternal ratio equals umbilical vein versus maternal venous concentration. What happens with inhaled anesthetics? There's placental transfer occurs for all the inhaled anesthetics. They have low molecular weight and lipid solubility. Usually MAC is reduced by about 30 to 40% during pregnancy due to progesterone effect and beta endorphins. Decreased uterine blood flow can happen with inhaled anesthetics. Obviously, fetal depression, dose-dependent uterine relaxation, with the exception of nitrous oxide, and decreased fetal heart rate variability less than the opioids or IV agents. What about the local anesthetics? The transfer across the placenta depends on the pKa, which is defined as the pH at which the drug is 50% ionized. So any local anesthetic with a pKa closest to physiological pH will have a higher concentration of non-ionized phase that can pass through the nerve cell membrane, hence more rapid onset. Drugs with pKa near 7.4 have a very, very high transfer. So the concept of ion trapping that we talked about earlier, in which fetal acidemia enhances the maternal to fetal transfer. This is just a table showing the most frequently used local anesthetics on both the amides and the esters and their corresponding pKa's. What about vasopressors? We know that historically ephedrine has always been preferred over phenylephrine until recently. Ephedrine crosses the placenta with a fetal-maternal ratio of 0.7. Both ephedrine and phenylephrine cause venoconstriction, which improves venous return and increases cardiac output, restoring uterine perfusion. Remember, the most important thing is maintenance of uterine perfusion. Now, phenylephrine, which is the agent of choice that has been proven in many studies recently, causes mesenteric venoconstriction with increased cardiac preload, improving uteroplacental circulation. Now, why is phenylephrine better? We know that ephedrine is a beta agonist, mostly, readily crosses the placenta, and can cause fetal beta adrenergic stimulation with increased fetal catecholamine levels, increased fetal heart rate and oxygen consumption, and the potential for fetal acidosis. So phenylephrine, from this fetal acidosis perspective, it's much, much better. What about the anticoagulants? Warfarin or Coumadin can cause fetal loss in congenital anomalies. So the best thing is to use heparin if you need to anticoagulate a patient. It does not cross the placenta, even at concentration used in acute thromboembolism, which can be very high. Other anticoagulants, low molecular weight heparin, enoxaparin, fondaparinux, have no placental transfer, especially in vitro studies with fondaparinux. What are drugs, in summary, that do not cross the placenta? All paralytics, glycopyrrolate, insulin, and heparin. Drugs which cross the placenta, opiates, morphine, fentanyl if more than 1 mic per kilo, benzodiazepines, ephedrine with increased metabolism, local anesthetics, atropine, and beta blockers. Safe drugs, propofol, thiopental, ketamine, fentanyl in less than 1 mic per kilo, and epidural opioids. Moving on to labor analgesia and anesthesia. Question: Pain in the second stage of labor cannot be managed by which of the following? A. Paracervical block. B. Lumbar epidural analgesia. C. Spinal. D. Pudendal nerve block. E. Caudal block. The correct answer is A. Paracervical block. This is the correct choice since this procedure may block some pain associated with dilation of the cervix, but will fail to block the pain of the uterus contracting. All the other answers are good for second stage. So which are these stages of labor? There's the latent phase on the left-hand side. The active phase, this all considered first stage based on cervical dilatation here. Then once the cervix is fully dilated, that's the start of the second stage, and then the postpartum period. Pain of childbirth. There's visceral pain and there's somatic pain. Visceral pain on first stage, lower uterine segment and cervix, usually dermatomes T10 to L1. And somatic pain, second stage, distension of the pelvic floor, vagina, perineum, usually dermatome S2, S3, and S4. And on the right-hand side there is just a picture showing the issues with visceral pain and somatic pain. Now, what are some of the medical effects of labor pain? Why is it that for many years we thrive to decrease labor pain? Well, pain compromises placental blood flow. And remember, what we have said several times during all these presentations is that the main issue in obstetric anesthesia is to maintain placental blood flow. So if pain compromises this could lead to fetal hypoxia and acidosis. There's increased catecholamine secretion with labor pain, leading to increased blood pressure, which again can adversely affect fetal circulation. Labor pain can also cause releases of adrenocortical hormone, which may affect issues like electrolytes and different metabolisms. And labor pain can also cause a traumatic labor that may lead to post-traumatic stress syndrome. So many issues as to why it is important for us to decrease or minimize labor pains. What can we do? Well, for systemic analgesia, very commonly used narcotics, opioids, like morphine, fentanyl, remifentanil more recently. Now, narcotics may decrease the progress of labor because it may reduce the force or rate of contractions. Obviously, this is dose dependent. Also dependent on the timing of the doses. The biggest effect is in that latent phase that we showed earlier in that picture. In the active phase of labor narcotics, that may speed up the process of labor by decreasing anxiety and decreasing catecholamines. Hence, the timing of when to give the narcotic becomes very crucial during this delivery, labor and delivery. Also, the narcotics can cause a decrease in long and short-term variability, causing the potential for respiratory depression. Hence, continuous IV infusion or PCAs causing better pain control and less placental transfer. What are some of the potential neonatal effects of narcotic analgesics? Well, some studies have shown behavior changes up to 4 days post-delivery, and some other issues in the neonatal stage, in which they can have depressed visual and auditory attention and decreased social responsiveness. So what if we have a depressed neonate? Let's say you're involved in the operating room, you're working in a particular place where there's no neonatologist, pediatrician has not arrived, perhaps in an emergency, C-section, etc., and the baby's born depressed. What can we do as anesthesiologists to resuscitate that infant that now has been born? Well, obviously, one of the things that historically can be done is to use naloxone or Narcan. Naloxone displaces the narcotics from specific receptors in the central nervous system and acts within 2 minutes of an effective duration of at least 30 minutes. Can also be repeated in 3 to 5 minute intervals. The new kid on the block is remifentanil that can be used either IV or in a PCA pump. It's an ultra short-acting synthetic opioid. It's a selective mu opioid agonist. Has a very rapid onset with a peak effect of blood and brain equilibration time of 1.2 to 1.4 minutes. It is susceptible to rapid metabolism by nonspecific blood and tissue esterases and short duration of action that's independent of duration of infusion. So, techniques for labor analgesia in summary: for first stage, epidural, continuous spinal, caudal analgesia, paracervical block, etc. For second stage, epidural, spinal, combined spinal anesthesia, caudal analgesia, and pudendal nerve block. Potential complications: obviously dural puncture, subdural injections, intravascular injection, etc. There's been recently case reports on broken epidural catheters, etc. So all of these things we have to keep a keen eye on preventing. Thank you.